quite timely to talk about chronic liver disease in children, the diagnostic and therapeutic approach. So let's see. I have no disclosures and all the images in this presentation are shared with permission. Firstly, I thought I would introduce the topic in this way. If we take a normal liver and a chronically diseased liver, if you just look at these pictures, on your left-hand side, this is actually a normal liver. This picture was taken during one of the liver transplants for a child, one of the living donor liver transplants, and this is actually one of the donor's liver on your left side. And you can appreciate what's the normal appearance of the liver. On your right side, it's one of the children's liver, actually, one of the explants who had chronic liver disease, cirrhosis, and who underwent liver transplant. So I think it's very clear the difference between a normal liver as well as a chronically diseased liver. Having that in mind, let's see the definition of chronic liver disease. This is actually a theoretical definition, but let's see what it says. Ongoing inflammation in the liver for at least 6 months with the potential to progress to cirrhosis and end-stage liver disease. This is the definition given by Espagan as well as the Espagan and the European Society of Liver Transplantation. Having that theoretical definition in mind, this is what we see in the wards. These are the different types of children we see in the wards. You can see infants, toddlers, and older children at different clinical stages. So can we apply that definition in our clinical setup? Would that be that much simple to use that definition? So let's look at the diagnostic approach, having that definition in mind, because that says inflammation. That's just a histological definition. But having that in mind in our clinical setup, in ward setup, how can we diagnose chronic liver cell disease? I would like to put the matters in this way. I would say we can use a stepwise approach. Firstly, we need to find out whether there is chronic liver cell disease or chronic liver disease. If so, what's the etiology? Most of the time, we would try hard to find out the etiology. Then, what are the complications this child has developed as a result of chronic liver disease? Firstly, I would like to discuss the diagnosis of chronic liver disease. If a child comes with symptoms related to liver disease, maybe jaundice, maybe abdominal pain, pruritus, is this really chronic liver disease? Or is this just acute hepatitis? Or is this just acute liver failure? So what are the features which should suggest a chronic liver disease in a child? Actually, we can use our clinical signs as well as lab tests, imaging, histopathology, and sometimes the endoscopy also would give us a clue. Clinically, what are the features which should tell you this child has got chronic liver disease? If they present with jaundice, it's not necessarily chronic liver disease. It may be just an acute hepatitis. On examination, if you have a shrunken liver, we know on routine abdominal examination, we perform percussion. And if there's a reduced liver span or shrunken liver, we would think about chronic liver disease. In addition, if there is a palpable left lobe or splenomegaly as a result of portal hypertension, that would again tell you this child is having chronic liver disease. The reason for the splenomegaly is portal hypertension, which would happen as a result of chronic liver disease, because splenomegaly cannot happen overnight or within weeks. That is why it will be absent in acute hepatitis or acute liver failure. If you have edema or ascites, again, those are manifestations of the chronicity of the disease. They have to have low albumin and decompensation for them to have edema. And ascites, again, together with low albumin, they would have portal hypertension, causing ascites. And stigmata of chronic liver cell disease like clubin, spider nevi, leukonychia, all these things would suggest chronic liver disease. Just to highlight, jaundice, pruritus, though they are symptoms of liver disease, they are not necessarily signs of chronic liver disease. They can be there in acute liver failure or acute hepatitis. How would lab tests help? Low albumin is essential. It's essential in decompensated cell disease. Sometimes in compensated chronic liver cell disease, they might compensate to have a normal or near normal albumin. High INR or prothrombin time might be there, but it can be there in acute as well as in chronic. Low platelets as a result of splenomegaly and portal hypertension would suggest chronicity. Imaging, they might indicate, the ultrasound scan might indicate increased echogenicity, coarse nature of the liver, though it is not specific, might help you. Fibroscan, again, the degree of fibrosis, OCT and MRI might tell you the chronicity of the liver disease. Histopathology is the gold standard, though it is not, we can't do it in every patient every time sometimes, but it is the gold standard to say there is inflammation and fibrosis, which would tell us there is chronic liver disease. If you perform an endoscopy, presence of varices would indicate portal hypertension, again indicating chronic liver disease. There are other terminologies which are linked to chronic liver disease. We often use these terms: compensated chronic liver disease, decompensated chronic liver disease, acute on chronic liver failure, end-stage liver disease. Let's take a minute to understand the difference as well as the meaning of these terms. We already know chronic liver disease. It's a histological definition, but clinically and lab test-wise, we can get a clue for the chronicity of the liver disease. If there are three features in that child, or one of the three features, that would indicate decompensation. What are those three features? That would be ascites, hepatic encephalopathy, or acute bleeding manifestations. If you have one or all three features, that would indicate decompensation. For example, if you have a child with ascites, yes, that is decompensated chronic liver cell disease. Similarly, hepatic encephalopathy or bleeding manifestations. Again, it's a common misunderstanding that jaundice would indicate, the presence of jaundice would indicate decompensation. That is not. Even in acute hepatitis, you might have jaundice. Acute on chronic liver failure, or ACLF, is it different to decompensated chronic liver cell disease? Yes. Even JPGN, there was a publication which indicated that ACLF is a different category, different disease entity compared to decompensated chronic liver disease. Decompensated chronic liver cell disease, you have a child who's known to have chronic liver cell disease and you see episodes of decompensation or gradual decompensation. However, in acute on chronic liver failure or ACLF, usually that happens in Wilson disease or autoimmune liver disease, where they get an infective trigger and suddenly come with the picture of acute liver failure. However, when you look back, there are signs of chronicity. So that is ACLF. End-stage liver disease, again, the terminal stage of the liver disease may be interchangeable with the decompensated chronic liver cell disease. This is just to indicate the remarkable ability of the liver to compensate. If I say this child who was walking and talking carried this liver, you might question me, but that is true. This liver was so much damaged. However, she was able to maintain her essential functions as well as just talking, walking with this liver. That is because of the compensation ability of the liver. So far I discussed the diagnosis of chronic liver disease. I hope now you are very much clear how to identify a child in the ward setup having chronic liver disease. You will look at the features clinically as well as by lab test, and will get guided by the imaging as well as the histopathology. Once you have established the diagnosis of chronic liver disease, we will have to move to the next step. That would be looking for the etiology. Etiologies are actually different from an adult to child. You can't extrapolate all the etiologies which are seen in adults to children. It's so much different if you look at the etiology profile. I would say I can classify the etiology of chronic liver disease into three main categories. There are diseases which would present in early childhood liver diseases which would invariably evolve into chronic liver disease with time. There is no escape from it. So we were talking about etiology of chronic liver disease. So there are early childhood liver diseases which will evolve into chronic liver disease, like biliary atresia. Even though they have Kasai, still they will progress into chronic liver disease and will ultimately require liver transplantation. Similarly, the genetic disorders like PFIC, progressive familial intrahepatic cholestasis, yes, they will definitely progress into chronic liver disease. Secondly, there are the treatable liver diseases like autoimmune liver disease, Wilson disease. If they present early, we might prevent the progression into chronic liver disease. So that's the second category. And there are other causes like drug-induced liver disease. We commonly see chronic liver disease following chemotherapy, as well as following methotrexate, which is used for arthritis conditions, and various drugs causing drug-induced liver disease. And sometimes the transfusion-related hemosiderosis as well. So those are the three main categories of etiology of chronic liver disease. Most of the time you will be able to find an etiology, but mind you, sometimes you might not be able to find an etiology. Still, you have to manage these children. This is just to give you the disease conditions list. Actually, the list is quite bigger, but this is just to tell you the spectrum of the liver diseases in children. I've highlighted biliary atresia because that is the commonest liver disease requiring liver transplant in children. Thirdly, we have actually looked at the diagnosis, etiology, and now thirdly, we can look at the complications associated with chronic liver disease. So these are the main complications which we encounter in our day-to-day practice. Portal hypertension is very, very common. If you see a child with chronic liver disease, invariably you will see portal hypertension. Secondary portal vein thrombosis. It might be quite uncommon to hear, but it does occur because in chronic liver disease, they have the deficiency in clotting factors as well as anti-clotting factors. With the development of the portal hypertension, they get sluggish portal flow, which will increase the risk of thrombosis. At the same time, they have a deficiency in anti-clotting factors, which might cause secondary portal vein thrombosis in the background of chronic liver disease. They can develop malignant nodules, fat-soluble vitamin deficiency. Pruritus, one might say that's a clinical feature or an association. The reason I've put it under complications is because we have to give an important care, as well as we have to give due importance for the pruritus because it does carry important steps in management. Hepatopulmonary syndrome, a unique complication we see mainly in children with biliary atresia. That's very important because that itself would become an indication for liver transplantation. And coagulopathy. We'll discuss these complications in next slides. So far, I've given you some idea about the diagnostic approach. How would you diagnose chronic liver disease and how would you look for the etiology? What are the possible etiologies? As well as how would you look for the complications? If you take individual disease, the investigations you do are different, which is beyond the scope of this lecture today. However, those are the three main steps you would undertake when you evaluate a child with chronic liver disease. Let's now look at the therapeutic approach or the management approach. Again, I would like to give you the principles of management of chronic liver disease like this. You have general management. Irrespective of the etiology, you have general things you would do to a child with chronic liver disease. And specific management. Like autoimmune liver disease, you have disease-specific therapy like steroids or other immunosuppression. Wilson disease, you have chelators. That is specific management. And management of complications. Ultimately, most of these disorders would require liver transplantation unless they are cured at very early stage. So when I talk about management of specific diseases, we all would be very keen to manage the disease and prevent it going into liver transplantation. However, if you take the disorders or the pediatric liver diseases, unfortunately, only very few diseases are there which can be cured or controlled by specific medical therapy. It's only Wilson disease and autoimmune liver disease you have specific therapy, and sometimes the viral illnesses like hepatitis B and C. If you look at this list, all the other disorders would ultimately require liver transplantation if they present late, or some of the disorders, anyway, it will require liver transplantation. So let's now look at the general management, irrespective of the etiology. What would we do irrespective of the fact that we find the etiology or not for a child with chronic liver disease? I thought I would discuss portal hypertension and GI bleeding first because that's very important and commonly encountered in day-to-day practice. So the type of portal hypertension I talk here is the hepatic type or the cirrhotic type of portal hypertension. And it's very common that they present with acute GI bleeding. Actually, the data are very, very limited in pediatric practice. If you just see this expert opinion in this article, they clearly say very limited data because it's very difficult to get the ethical approval for this type of clinical trials in children. However, we adopt most of the data from adults, which might not be correct actually. When you manage portal hypertension, there's a role for medical management where you would use either beta blockers or losartan to minimize or to reduce the pressure in the portal system. We normally use or prefer using losartan in infancy. The reason is we try to avoid beta blockers in infancy because the hemodynamic response in response to bleed is beta receptor mediated. So we don't want to block that response in case of acute bleed. Hence, we use losartan instead of beta blockers. Various beta blockers can be used. Most of the studies were done with propranolol. However, we have adapted adult data and now we prefer using carvedilol. Together with these portal pressure lowering drugs, we can use PPIs as well as sucralfate. An endoscopic management is the most effective when you talk about portal hypertension. The band-in, if it is possible, in a kind of a child who's maybe more than 1 year, if you can pass a bander through endoscope, the band-in is the most effective therapy for varices. If you can't control portal hypertension, maybe you ban esophageal varices till the child bleed, or else if you have varices in the stomach, duodenum, or the child bleeds from portal hypertensive gastropathy, then you have to consider liver transplantation as the ultimate cure. This is just to tell you how to manage an acute bleed because that is life-saving. It's very important. Initial resuscitation is very important. You put 2 cannulas and give fluid boluses, then blood transfusions and monitoring. That is very important. And you keep the child nil by mouth and put an NG tube for open drainage. Drugs-wise, you can use octreotide or vasopressin. It's very important you cover them with antibiotics. The reason is acute bleed can cause further decompensation of chronic liver cell disease and they can die during a bleed due to decompensation and encephalopathy, not due to bleeding. So it's very important you cover with antibiotics. And target hemoglobin during a bleed or anyway in a child with chronic liver cell disease is 7 to 9 or maximum 10, I would say. If you over-transfuse them, again, there's a likelihood of bleeding by filling the intravascular compartment more than they can tolerate. So just tolerate a low hemoglobin, which might be 7 to 9. And you can use intravenous PPIs as well. It's very important you give a bleeding letter to the child on discharge. The bleeding letter would carry all the information to be done in a kind of an acute bleed. If the child presents with acute bleed next time, even the house officer would know, house officer would see the written instructions for management of an acute bleed. That is the meaning of a bleeding letter. The next complication or the association is ascites. Ascites in a child with chronic liver cell disease is multifactorial. It could be due to low albumin as well as contributed by high portal pressures. And to complicate the matters, child might have secondary portal vein thrombosis on top of cirrhosis as well. In children, the main modality of correction of the management, I would say, the control in ascites would be albumin transfusions and diuretics. You might see therapeutic paracentesis in adult practice a lot, but in children, the mechanisms are different and their body weights are quite low, so you can use albumin without having a much cost. So it is mainly 20% albumin transfusions with diuretics. We manage ascites in children. There's a place for low salt diet in older children, as well as volume restriction. But the main message is we do not do therapeutic paracentesis unless it impairs the respiration with gross ascites. You might do a diagnostic peritoneal tap if you suspect spontaneous bacterial peritonitis. Moving to coagulopathy, again, kind of a frightening complication. Most of the time, I see when we get the referrals, also the pediatricians and the clinicians are very worried about INR as well as the bleeding. Yes, I agree, they do get coagulopathy. However, hemostasis in liver disease is quite complex than simple coagulopathy. As I mentioned earlier, they can get coagulopathy as well as there's a risk of thrombosis as well. If facilities are available, try and use rotational thromboelastometry, which is a test which would give you kind of a 300-degree assessment of the hemostasis. It will assess the extrinsic pathway, intrinsic pathway, fibrinogen, platelets, everything. The risk of bleeding as well as the risk of thrombosis. So rather than going by INR and correcting it with FFP, the key message would be to get guided by ROTEM if the facilities are available. At the same time, one more important point to highlight, we often think it is the INR or prothrombin time, the prolongation of the INR, which would cause bleeding. Actually not. There had been children with INR of 8, 10 sometimes who hasn't bled. That doesn't mean you don't have to correct it when INR is 8. But sometimes we can accommodate INR of 4, 5 like, up to 5 like, provided their fibrinogen as well as platelets are corrected. Because it's a fact, they bleed more due to platelets and fibrinogen rather than due to extrinsic pathway defect. So I know we are very much frightened about INR, but actually that is not the culprit. It is mainly fibrinogen deficiency as well as low platelets which occur in the setup of chronic liver cell disease. Another important complication is hepatopulmonary syndrome. It's a very common complication, and due to some reason it is very much associated with biliary atresia. I haven't seen it in association with Wilson disease or autoimmune liver disease, but it's very common with biliary atresia. It's very important when we follow up children with biliary atresia in the clinic, they look very well, but do not forget to check saturation. You have to check the saturation in upright position as well as in the supine position. In hepatopulmonary syndrome, they feel better in the supine position. Okay, and that will be an indication for liver transplantation, provided their synthetic functions are normal, they are well, otherwise still it would be an indication for liver transplantation. The other important fact is if they progress with hepatopulmonary syndrome and if their saturation become very much low, we would say if it goes below 92%, we have to anticipate a lot of anesthetic as well as postoperative complications. The outcome of liver transplantation might become poor. So that's why it's very important we diagnose hepatopulmonary syndrome early. If you have a doubt about saturation, perform arterial blood gas and get a bubble echocardiogram done. If that is positive, even with the slightest doubt, please do refer for liver transplantation. Another important aspect of management in relation to chronic liver disease is nutrition. I would consider nutrition as a medication for a child who's having liver disease. And one of the problems in assessing nutrition would be they would have a good weight. If you see this child, the child's weight is actually normal. It will not show any severe acute malnutrition or moderate acute malnutrition if you plot in the weight for length or weight for height chart. Because the child will carry some weight due to hepatosplenomegaly, ascites, bowel distension, all these factors would give a weight. If you look at the limbs, you can note that they are very thin, with thin muscle mass as well as less subcutaneous fat. So this child, though the weight comes as normal, this child is significantly malnourished. Their intake is limited because they have loss of appetite, and they are on a list of medication which would make their appetite worse. So their intake is less. Their capacity to hold the food in the tummy is less because their tummy is occupied with hepatosplenomegaly as well as ascites. And sometimes they do have bowel distension as well if they have recurrent episodes of cholangitis. Though the intake is less, their expenditure is high, their basal metabolic rate is high. And on top of that, they have fat malabsorption and vitamin deficiencies as well. So it's very important we find an individualized manner, maybe sometimes frequent small feeds with high calorie. They might benefit from that kind of a feeding with these limiting factors. As I mentioned, the assessment of nutrition is a challenge because of their weight becoming normal. So you might use alternative anthropometric parameters like mid-upper arm circumference. And one more fact to emphasize, in special disease conditions like Wilson disease, I know it's quite fashionable to say that you have to restrict copper in the diet, but taking the advantages and disadvantages, when one child is on chelators, we would not normally ask them to restrict any form of diet. So if you have a child with Wilson disease, you do not have to tell to limit chocolate or nuts when they are on chelators. That's a common myth we encounter in our clinical practice. When one is on chelators, what you get by the diet is very minimal. So we don't want to compromise their nutrition by giving that kind of advice. We would ask them to take whatever they want. Another important management point I wanted to discuss is pruritus. There are specific liver diseases which would carry a very high risk of pruritus and intractable pruritus, I would say. Etiological syndrome, progressive familial intrahepatic cholestasis, bile acid synthetic disorders, and sometimes biliary atresia would result in medically refractory pruritus. So there are a few things that we have to do. There are general things we can do as well as specific things. The general things are, you can ask the patient to keep the skin moist as well as keep the nails short and avoid heat. Maybe if they have the facilities, use an air conditioner, just the general measures to minimize the pruritus. And there are some medications you can use like ursodeoxycholic acid, cholestyramine, naltrexone, and sometimes we do use rifampicin when the child has significant pruritus. But rifampicin, you have to be very cautious. You use it when you don't have any other reserves, because given the fact that it's anti-TB medication, we can't misuse it in a country like Sri Lanka. So we use that when we don't have any other methods of controlling pruritus. And sometimes in certain disorders like PFIC, you can use the surgical method of biliary diversion. So once we have done all our general measures and medical management, still there are children who would have intractable or medically refractory pruritus. In these pictures, you can see one of the children with Etiological syndrome. If you can appreciate, the skin is very much thickened and the child has got loads of scratch marks in the back. And if I'm to share the real life story, what the child's parents told me, even if they give a toy or something to the child would not play with the toy. Instead, child would use that toy to scratch. So that's the story I hear from the family. So it's very troublesome, and they don't have a sleep at all. The child would not have a sleep at all, and the family would not have a sleep at all. So sometimes we have to consider liver transplant, and it is an indication. The liver transplant is an indication for medically refractory pruritus in certain occasions. The next complication I would like to discuss is infections. There are liver-specific infections like cholangitis or spontaneous bacterial peritonitis, and sometimes chest infections are quite commonly seen in children with liver disease. One of the reasons is they get shallow breaths because they have a full tummy due to hepatosplenomegaly and organomegaly and ascites, and they are anyway immunosuppressed. Their immunoglobulins are low and they get recurrent infections and nutrition is compromised. So they are vulnerable to get various types of infections. A little note on immunization. It's very important if you see a child with chronic liver cell disease to complete routine vaccination. That is important as for any other child. And sometimes you might have to give accelerated schedules if you are planning for liver transplantation, because following liver transplantation, they would be on immunosuppressive therapy. So you might have to give the vaccines before that. Something is happening with the slide. Sorry. And extra vaccines are important, like pneumococcal vaccine, because pneumococcus is a common organism which would cause spontaneous bacterial peritonitis. And if you are planning for transplant, it's very important you give varicella if possible, and check the hepatitis B antibody levels and give a booster. Immune response which is generated might not be the optimal, but still you have to give the vaccines as usual. One important fact, before you vaccinate them, you just have to check their coagulopathy and the clotting status, because if you just vaccinate them with intramuscular route, they might get hematomas. So be mindful to check their clotting before you administer vaccines, and you can use deep subcut route instead of IM route. Other complications would include hepatic encephalopathy, again commonly seen with acute liver failure. Sometimes you can see with decompensated chronic liver disease. Hepatorenal syndrome also can occur, but that is quite less common in children. Normally, we get that manifested soon after liver transplant. Their kidneys are holding on, they have a degree of hepatorenal syndrome, but soon after liver transplant, after prolonged surgery, they get AKI. Cirrhotic cardiomyopathy and portopulmonary hypertension are quite uncommon in children. This is the list of medications usually you see in a child with chronic liver disease. Invariably, they'll be on ursodeoxycholic acid, which would indicate the bile drainage. Fat-soluble vitamins are important. Water-soluble vitamins are also important. And diuretics, if they have ascites, especially biliary atresia and PFICs, you need to give prophylaxis for cholangitis and prophylaxis, medical prophylaxis for portal hypertension, rifaximin in view of hepatic encephalopathy, laxatives, again in view of hepatic encephalopathy to maintain their bowel opening, and antipruritic medications. In a given child, you might not need to use all these medications, and sometimes if the list is quite long, I might skip the non-essential ones in clinical practice, like water-soluble vitamins, because it's not easy to take 10 or 15 medications, and it's not easy to give this type of medications, this number of medications for a small child. So you have to be practical. Sometimes you have to pick the ones which are quite important. Counseling and psychological support crucial, because these are children and families who suffer from a chronic disease. Various problems do occur, so we have to consider this as an important part of the management. The ultimate cure for most of the pediatric liver diseases is liver transplant, and the results are promising. If you look at the West and the affluent countries, the history of liver transplant goes to 3 decades, and it has become the standard of care. It's not just the surprising treatment, it's the standard of care for chronic liver disease when there are indications. So these are the indications. If you have a child with chronic liver disease, irrespective of the etiology, if they have declining in liver synthetic functions, if the albumin is dropping less than 3.5 consecutively, and if your INR is rising more than 1.5, then you have to consider liver transplantation. Earlier the transplant, better the outcomes. Unresectable malignancies and life-threatening recurrent cholangitis, uncontrollable portal hypertension, hepatopulmonary syndrome itself without any other indication might become an indication for liver transplant. As I mentioned earlier, refractory pruritus is again an indication for liver transplant, and they'll be cured in regards to their pruritus. These are relative indications, the osteoporosis or the hepatic osteodystrophy and impaired growth and puberty, as well as in metabolic liver disease, frequent and severe metabolic crisis would become an indication for liver transplantation. Of course, there are contraindications which are very few. If you have disseminated malignancy, if you have a disseminated infection or immunodeficiency condition, you would not consider liver transplant. At the same time, like mitochondrial disorders, if you have multi-system involvement, By transplanting liver, you are not going to cure the child because there are other organs which are affected. Then you would not consider liver transplant as a therapeutic option. Age and size of the child is not a limitation for liver transplant. It's true that we might not consider liver transplantation for very young child with the expertise and resources available at present locally. But if you consider the best and a best developed center for liver transplant, they might transplant even a day 5 or day 4 old baby. And the size of the child is also would not matter. And sometimes I've heard this that you need to have 10 kilograms, 15 kilograms to go through liver transplant. There is nothing like that. Once it is indicated, irrespective of the weight that is indicated. What matters whether you can do it or not is the expertise and the infrastructure which is available. Just to share some of our success stories of liver transplant, these were 3 milestones we made together as a team. On your left-hand side, you can see the first successful pediatric liver transplant in Sri Lanka, which was again done by the CNCAD team, Ragama. And now she has marked 3 years of post-liver transplant, and this is a picture with her family recently. And the second one in the middle is the youngest successful transplant we did as a team, 1-year-old child who had acute liver failure, actually. Thirdly, again, this is a child with Wilson disease who had decompensated chronic liver disease, the most recent success story, and he's back to school after liver transplant, and this picture was taken after 3 months from the transplant. Having said all about the management, the follow-up is also important. We have to have an individualized approach. The disease is different, their clinical course is different, the stage of the chronic liver disease is different. And it's always good to have shared care with a transplant center, which might put some light into better management as well as early transplant if that is indicated. If possible, if you can share a helpline with these patients because they are chronically sick, that would be important, and support them. And when you monitor them, when you follow them up in the clinic, you can use your clinical parameters, lab parameters, imaging, as well as endoscopy to get an idea about the child's status. So far I hope I've given you some light on diagnosing chronic liver disease clinically in the ward setup, and how to look for the etiology and how to look for the complications, the general management of a child with chronic liver disease, what are the important aspects, and a bit about liver transplantation. Now I thought I would share a few real life cases just to put the theory into the practice. So the first patient I would like to share, this is a 10-year-old boy who presented with jaundice, abdominal distension and ankle edema for 2 weeks. He was previously well and he was not on any medications long term, and there was no family history of liver disease. And you can see the examination findings. He was jaundiced, pale, had edema, and there was left lobe palpable on examination with splenomegaly. He did have ascites. What are the possibilities? Does he have chronic liver disease? Yes, he did have chronic liver disease because he has all the features like splenomegaly, ascites. He did have liver disease with chronicity. And there were features of decompensation because he had ascites. What are the possibilities for the underlying etiology? These are the possibilities we would consider if you get a child with chronic liver disease at that age. Autoimmune liver disease, Wilson disease are very common. It's often the practice we look into very rare genetic and metabolic things, but mind you, autoimmune liver disease and Wilson disease would comprise 85 to 90% of the chronic liver diseases at this age. Then you have to think about drug-induced liver disease, rare metabolic and genetic, and hepatitis as well. So these are the possibilities. Let's look at the investigations. So he had some degree of transaminitis, and he had impairment of his clotting. And you can see bilirubin values. You can see the albumin being very low, 19. And he did have significant anemia. Together with that, if you interpret the bilirubin, There's a direct component as well as a significant indirect component as well, together with this low hemoglobin, which suggests concomitant hemolysis. And blood picture did have evidence of hemolysis. So what did the further workup show? He did have positive cave rings, low ceruloplasmin. We did not do 24-hour copper because we went ahead with the genetics straight away for Wilson disease. All the other investigations were negative. So we know Wilson disease is a multisystemic disorder which affects multiple organs, but liver and brain mainly. And you can use this diagnostic score when you think about the diagnosis of Wilson disease, which would have clinical features, lab features, genetics, imaging, where a score of 4 or more would tell you the possibility of Wilson disease is quite high. There are medications as chelators, which would have a good role to play. However, if they fail, the liver transplant would be the ultimate cure. What did we do for this patient? We did start chelators and we did all the other steps for the chronic liver disease. However, he did progress into decompensation, so we had to list him for liver transplantation. And we prepared the donors as well. So ultimately, we could not transplant this patient actually when we have prepared all the donors and he was listed and we were just few days ahead of transplant. Unfortunately, this was at the time of the COVID-19 pandemic and he did die due to COVID-19 and we could not make the transplant for him. But that was the story. The second patient, a 4-month-old boy, who's come in with persistent jaundice, pale stools and dark urine since first week of life. There were no perinatal issues and parents were non-consanguineous without any history of liver disease in the family. He was quite well grown and deeply jaundiced and had some ascites and splenomegaly. So does this child have chronic liver disease? Yes. He did have chronic liver disease with decompensation because he did have evidence of liver disease with chronicity, which was evident by splenomegaly and ascites. That's why we say there was decompensation as well. What could be the cause in this 4-month-old baby? That is different to the boy we discussed earlier. So at this age, the commonest thing we would consider is biliary atresia. This was actually a late presentation of biliary atresia. At the same time, it could be Alagille syndrome, congenital infection, or other metabolic disorders. Let's look at the lab test. How were they? You can see there is prolongation of the prothrombin time and low albumin, again supportive evidence for chronic liver disease. And his bilirubin was quite high. And ultrasound scan showed evidence of chronic liver disease. What was the ultimate diagnosis? It went towards the line of biliary atresia, where we diagnosed it clinically, but I did not go ahead with a cholangiogram or Kasai because it was a late presentation. So this case actually raises the importance of identifying a baby with prolonged jaundice and having pale stools. Because the case I discussed was actually a delayed presentation of biliary atresia. The child presented at the age of 4 months with decompensation. There is no point doing Kasai. Actually, it is harmful to do Kasai at that stage. That will only add complications. So we just need to plan liver transplantation primarily for very late presentations of biliary atresia. You can consider Kasai if they present less than 3 months of age and if there are no features of decompensation. For this child, we considered liver transplantation as the primary therapy. And he was actually transplanted and now he's doing well following liver transplant. If he presented early, we would have offered him Kasai and we would have delayed the need for liver transplantation. If possible, it's very important to delay the need of liver transplantation due to multiple factors. I mean, it carries morbidity as well as the child is exposed for immunosuppression. So if it is possible, it's always important to delay liver transplantation by performing a Kasai. But for that, you need to identify biliary atresia early. So this is the last case I would like to discuss. We had a 2-year-old girl who had persistent pruritus since early infancy. Initially followed up in the dermatology clinic for a dermatology condition. They were suspecting a dermatological condition. There was no jaundice. Parents were non-consanguineous and there was no family history of liver disease. On examination, when she presented to us, she had multiple scratch marks, thickened skin, hepatomegaly as well as splenomegaly, but there was no ascites. And we detected medically refractory pruritus subsequently when we started managing her, which was impairing her quality of life. So is this chronic liver disease? Yes, because she did have evidence of liver disease with splenomegaly. But there were no features of decompensation, as there were no features like ascites, hepatic encephalopathy, or bleeding. What are the likely causes? So these were the differential diagnoses we considered because the child had medically refractory pruritus, Alagille syndrome, PFIC, bile acid synthetic disorders were the priority. Biliary atresia is quite less likely because you can't wait without going into end-stage liver disease at 1 year. This is not the picture of biliary atresia. So if you look at the lab parameters, you can see the albumin is marginally low, transaminase is slightly raised, but bilirubin is actually normal. The pruritus was due to raised bile salts. You can appreciate the bile salt level, which was 150. And we suspected Alagille syndrome clinically. However, her echo was normal. It did not show pulmonary stenosis. She did not have posterior embryotoxons and there were no butterfly vertebrae. We did not consider liver biopsy because we wanted to go ahead with whole exome sequencing genetics because liver biopsy will not give us a conclusion, but the genetics will give us. So as we expected, whole exome sequencing gave us the conclusion it was Alagille syndrome. The reason I wanted to share this case, there were a few reasons I wanted to highlight. One is to highlight the fact this child did have chronic liver disease, though it was not very much evident with the features of decompensation. Number two, though this was a case of Alagille syndrome, she did not have echo or eye evidence or vertebrae evidence of Alagille syndrome, which we would expect. So still we have to consider Alagille syndrome. Absence of these things would not exclude Alagille syndrome. The thirdly, I wanted to highlight the importance of going through genetics, and in the current era, the biopsy is limited. Biopsy carries a limited value in this type of a situation. However, genetics are very helpful and it is the fashionable test in the current era. So for this child, what did we do? We did general management, medical management. However, still her pruritus is not under control. And parents are very much willing to go to a liver transplant because they say the quality of life is zero for that child as well as for the family. And they are very hopeful about liver transplantation. So at the moment, we are doing the donor workup for the liver transplantation. So far I have shared few theory aspects about diagnosing chronic liver disease, etiological aspects, as well as the complications and its management. And I thought it was important to share a few cases, few real life cases as well, just to put the theory into practice. The main take-home messages I wanted to highlight were the management of chronic liver disease needs more attention and an individualized approach because the cases I discussed are totally different from one to the other. And the diseases and their status are different. And sometimes it's very helpful to have a shared care with the transplant center because they might shed extra light into the picture and child will benefit from early liver transplant if that is indicated. That brings me to the end of the talk and thank you for your patient listening despite the interruptions in the middle. Thank you.
Madam, there are 3 questions in the chat box.
Yeah.
May I read that questions for you, madam?
I'm trying to see them. Yes, I think I can see them if that's okay. Yeah, I can read them out and answer. The first one is, what are the antibiotics in acute bleed? Yeah, the most liver safe and effective antibiotic we consider is piperacillin tazobactam, IV piperacillin tazobactam, 90 milligrams per kilogram 3 times per day. You can start with that, but that doesn't mean you have to give that for 5 days or 7 days. You cover it maybe for 48 hours, 72 hours, once the child is stable, just convert to oral antibiotic, maybe second generation or third generation cephalosporin, oral, and give a 7-day course. But in the initial stage where you don't know which direction patient would go and the risk of decompensation is high, we would consider piperacillin tazobactam. So that's the first question. The second one is, what is the prophylaxis for cholangitis? Yeah. When we use prophylactic agents for cholangitis, we try to rotate the antibiotics. We can use cefalexin, cotrimoxazole, amoxicillin, ciprofloxacin, various types of antibiotics, but we tend to rotate that every 3 monthly to avoid antibiotic resistance. That is one fact. And number two, especially children with biliary atresia, the type of agent sometimes depend on the type of organisms we isolate. They tend to have these bile pools within the liver, which are called bilomas. And if you can drain bilomas and culture them, then that sensitivity can be used to decide on your cholangitis prophylactic agent. The next question is, 8-year-old child presenting with hematemesis, resuscitated with IV fluid. What is the most appropriate next step? It has to be a blood transfusion, because if there is loss of blood, your fluid resuscitation is till you get the blood back. If the hemoglobin is less than 7, you have to replace it with blood. So next step should be, if the child is not settling, blood transfusion. What are the mechanisms of valproate-induced liver injury? That is idiosyncratic. That's the idiosyncratic reaction. So we don't really we have not identified a mechanism. It can happen if you have 10 people who get valproate, only 1 or 2 might develop it, and 8 might not develop, and you can't predict it. So unfortunately, I don't have a mechanism to share. Yeah, those are the questions, Maya.